that leaves scars, not just on our body, but on our heart and soul.
Cancer accounts for 20 million diagnoses annually and is one of the leading causes of death worldwide with nearly 10 million deaths. Tragically, India alone accounts for 32.9% of the total global deaths related to cancer. India's cancer crisis reveals this distressing reality, with breast cancer leading with 13.6%, followed by oral cancer at 10.2% and cervical cancer at 9%. These alarming statistics create the need for urgent action.
The threats posed by these three cancers can be compared to the Bermuda Triangle, where ships and planes disappear without a trace and dangers lie hidden. Similarly, these cancers strike silently, manifesting in advanced stages where treatment options are limited, thus making their treatment options limited, thus making this reality. Oral cancer, breast cancer, and cervical cancer. Screenings of these cancer
Availability of these screenings in the government settings makes it important to address them. Visual mucosal examination for those at high risk of oral cancer, clinical breast examination to detect breast cancer early, and visual inspection by acetic acid for easy identification of cervical cancer.
According to NPNCD, all individuals aged 30 to 65 should get screened for these cancers once in every 5 years.
Despite this, the current cancer screening uptake remains alarmingly low, accounting for 1.9% cervical cancer and 0.9% for both breast and oral cancer. This is still low. Our loved ones are crying. Are we still hearing or ignoring them?
As cancer continues to claim lives, are we aware of its threat or are we trapped in a cycle of ignorance? This led us to conduct a mixed cross-sectional study among 385 participants in the general adult population of Hyderabad. Our aim was to assess their beliefs and behaviors and to identify the barriers towards cancer screening. To enhance our research and to provide grassroots perspectives, we included community health workers as the second part of the research. Our first awareness assessment study has revealed a significant gap in cancer knowledge, with only 37% of participants had good knowledge about oral cancer, 23% had about breast cancer, and 21% for cervical cancer, underscoring the urgency for an improved cancer education.
To assess the correlation between socio-demographic variables and awareness as per our objectives, we conducted a chi-square test on 4 anticipated variables, all of which gave a statistically significant correlation of p-value less than 0.05.
In our findings, mean awareness score had a decreasing trend from 18 to 30 age groups to higher age groups, reflecting that lack of familiarity with disease during their formative years.
We observed a positive correlation between education status and awareness, indicating individuals with higher education status tend to have higher awareness.
People with a family history of cancer showed greater awareness, indicating that perceived severity and personal experiences drives health information seeking behavior.
Higher socioeconomic groups tend to have higher awareness. Despite this, the cancer screening uptake remained low across all socioeconomic groups.
This raises a haunting question. If effective screening methods can shield us from the devastation of these diseases, what barriers are holding us back?
Our literature review uncovered a critical oversight, the profound impact of individual beliefs and behaviors towards cancer screening decisions. The Champions Health Belief Model was used to identify the barriers using a semi-structured questionnaire. Our analysis yielded key findings. While 3/4 participants lacked knowledge about cancers and their screening altogether, others were unaware of its availability. Even among the informed, misconceptions prevailed. For breast and cervical cancer, cultural stigma hindered 71% participant screening decisions, wherein 78% participants perceived negative impact on sexual health, while the others feared partner disapproval. For oral cancer, underestimation of cancer risk and severity hindered 71% screening decisions.
Our study revealed significant barriers to cancer screening in communities, with doctors shouldering an immense workload workload, it becomes a voluminous task to gain a broad outreach. According to the World Health Organization, community health workers, who are the unsung heroes, have an immense potential to extend healthcare services in a culturally appropriate manner. Yet, their potential remains underprivileged.
Using a semi-structured questionnaire, we interviewed 26 community health workers who provided useful insights on our statistics on the barriers.
In our conversation with the community health workers, they mentioned community members, even those at high risk, underestimated cancer severity due to lack of knowledge, delaying health-seeking behavior until severe symptoms emerged.
Additionally, cultural barriers silence people, particularly women, associating these cancer screenings with shame. The reluctance of men to discuss women's health issues such as breast and cervical cancer highlighted the need to normalize these knowledge.
While community health workers are well positioned to make a difference, they mentioned cancer screening often falls low on their list of priorities due to their broad responsibilities and lack of necessary awareness even among them. By providing them with right resources and proper education, we can make them the torchbearers of cancer screening, reaching each and every part of the society.
Combating cancers requires implementation of comprehensive programs. ASHA workers are the heart of India's healthcare system and trusted voices in the community. Educational interventions through home visits, public awareness campaigns, and community outreach programs such as mass screenings and mobile vans can help in making cancer screening a household topic. Successful interventions such as mobile phone reminders like mHealth can be helpful for our country. We, as medical students, aim to expand our impact through the existing family adoption program by directly engaging with communities and breaking the myth and misconception surrounding cancer and its screening.
Additionally, our team developed an engaging audiovisual resource disseminating the critical knowledge about cancer, addressing cultural barriers to diverse audience with notable post-intervention knowledge increase.
India has always proven to rise in the face of adversity. We've overcome epidemics and advanced in the field of science and medicine. We've proven time and again, no goal is unachievable and no challenge is too great when we all are together. Yet, today, again we are here, fighting against this deadly disease, confronting cancer.
Do we need a crisis to wake us up to the power of prevention?
Will we allow cancer to silently claim our lives? The power of prevention is in our hands. Now is the time to act before it's too late.
Ladies and gentlemen, here and now we issue a call to action. Our goal today is to initiate a dialogue. Our efforts, though modest, we believe every small step counts. In this battle, there is no pen too small, no voice too faint. Every life saved is a victory for the nation.
India, together we stand tall. Together we stand strong. We all need to build a nation where we are not just cancer aware, but cancer resilient. We care for you. Get screened.
A moment to screen, but a future to save. Thank you.
Thank you.
Thank you.
Okay, wonderful presentation. I wish you could have kept the background music a little low so that we could have heard you. So you had to strain against the background music to be, you had to speak above the background music. That's all right. I'm quite aware of cancer screening programs. I've done the 100 districts program for the Government of India way back in 2013. So we trained every district health worker in those 100 districts. But having said that, the major problem we faced was the reluctance of any single government health worker to participate in the screening program. I leave that aside. I don't know whether you have included this side of the story. You only told that side of the story. So I can talk for hours on this side of the story as well. I will leave you there, but you had stressed on screening as the modality for cancer prevention. What would be the primary prevention of cancer according to you?
Thank you very much.
Screening is purely a secondary prevention. It is not called primary prevention. I hope you understand the difference. Okay, so did you ask questions of any relevance? Because I know there is one more topic, I won't elaborate on that. There's one more topic on HPV and awareness. So I will leave you there. But why did you focus only on screening and not on primary prevention?
Thank you very much for the question, sir. Sir, under the primary prevention for the cancers in general would be lifestyle modification, as alcohol consumption or tobacco consumption increase the chances of people getting oral cervical cancer. And for the cervical cancer, human papilloma virus, due to unsafe sexual practices, we understand that the behavior of we try to assess the behavior of people using the Champions Health Behavior Model.
I agree. So we are already doing primary prevention. Most of you are probably not aware of that. You give the hepatitis B virus. So hepatitis B virus, of course, will prevent. It is given before this child enters school, and then one more booster dose is given. And each time you want, you can check the titer of the anti-hepatitis B antibody and give a booster if you are below by the occupational health. That's fine, especially for healthcare workers. But we are already participating in that unknowingly. So most people don't know that hepatitis B virus infection, which leads to chronic active hepatitis, chronic persistent hepatitis, cirrhosis, and ultimately hepatocellular carcinoma is already being taken care of. We're not concentrating. Probably the moonshot initiative of our Prime Minister will lead us to vaccinate, universal vaccination against human papilloma virus. Can you tell me in your own words, what was let us say, if you offered a cancer screening program to everybody in the community, what percentage will take it up? What percentage will not take it up? Any idea? Let us say I do it for medical students. If I offer a cancer screening program for medical students or in a medical college to all sections, starting from professors all the way down to the class 4 employees, have you any idea what percentage will take it up? The reason I mention this is the most biggest barrier to cancer screening is the healthcare worker, nothing else.
Thank you for the question, sir. We according with our MBBS curriculum, we have been allotted a family adoption program. We go door-to-door survey, and then after that, a month later, we conduct a health camp. In that,
if you offered a program, what percentage will take it up?
Of the 10,000 houses we surveyed, when we had allotted a total turn-up, tabulated them, we could not even see close to 7 to 8% people showed up of the 10,000 houses we surveyed.
So it is like this. If I offer a cervical cancer screening program to a group of women, say 100 women, roughly at the first go, only 30% will take it up. If you sustain your effort over the next 6 months, you will typically reach around 60% only. There will still be, you have mentioned several very good barriers, cultural barriers, religious barriers, etc., etc. You said, education as a barrier. Yes, it is not just in our country, in many countries as well. So, yes, you are right, but it will never reach 100% unless you make it mandatory or compulsory. So, if you make it mandatory for you to obtain an Arogyasri card and renew it every 5 years, if you make a screening program mandatory, just like how you are screening your hemoglobin, blood pressure, and blood sugar, if you offered cancer screening program, it becomes mandatory. Nobody will. You take the COVID vaccination. If you did it on a voluntary basis, nobody took it. Even in a highly educated society like United States, roughly 70% of them did not take the COVID vaccine, belonging to one single political party. Agreed? So it comes as no surprise that if I said you can't come into the hospital to work, you can't come into the municipal office to work if you have not taken the vaccine, there everything becomes mandatory.
Yeah, from my side, one or two questions. I assume that 7 of you girls have got involved in this survey. Am I right? 7 of you. So majority of you are 7 of you are girls and 4 are boys. So did you all ask about their awareness on the primary prevention? As Sir said, are they aware of the availability of vaccination? Did you put a question on that? And are they willing to get vaccinated? What were the questions you have asked about the cancer cervix prevention vaccination, awareness? And that is the one thing. The second question would be, did you ask them about the awareness on self-examination of the breast? Did you ask and did you put some effort in demonstrating that?
Thank you for the question, ma'am. Ma'am, to answer your first question, we had first conducted an awareness assessment questionnaire on oral, breast and cervical cancer, where we found a substantially low percentage people having knowledge about the risk factors and the factors which can increase the risk of breast cancer. And even they had less awareness about the HPV vaccine also. And when we asked them their reluctance to get themselves screened for the to get themselves vaccinated,
reason for refusal of
Yes.
getting vaccinated?
Yes, ma'am. Ma'am, one of the main barrier found was the cost among the informed people. The people who knew about the vaccine, they were reluctant because of the cost. And in others, they were not aware of the vaccination available for HPV. And to answer your second question, ma'am, we also found under our awareness assessment questionnaire that a large proportion of women did not know about the self-breast examination. And when we interviewed those women, we did tell them about the self-breast examination. We have also taken a small initiative from our side where
How did you explain about the self-breast examination?
Yes. Ma'am, from our side, we have taken a small initiative. We had made an audio-visual presentation. We had gathered women and showed them through the audio-visual presentation the main risk factors for developing each of the cancer, and also we educated them about self-breast examination. We also told them that the clinical breast examinations and the examinations for cervical cancer screening.
Did you follow up and see whether they are practicing it?
Ma'am, due to the time constraint, we could not follow up, but the women did appreciate our program, our initiative, and they did assure us.
There was no follow up.
Yeah, they did assure us that they would do the self-breast examination regularly.
So nice presentation. From my side, I would want to know, you have said that with increasing age, the awareness went down, and level of education also you said was positively correlated. So another variable which you could have asked, or did you ask about people having family members with cancer? Did that affect the level of awareness of the screened population? So was there a question regarding that?
Thank you for the question, ma'am. In our questionnaire, we asked them, do you have any family history of cancer? And some of the members have told that they have the history of cancer, and those participants tend to have higher awareness, showing that having a family history tend to have higher awareness.
Okay, are there any government-supported programs, cancer screening programs available, and did you inquire about these programs from the community health workers? Do you have screening packages which are funded by the government?
Yes, ma'am. Under the Ayushman Bharat scheme, which is the world's largest financial medical scheme, it has initiated 3 cancer screening programs: oral cancer, cervical cancer, and breast cancer. Under that, all the PHCs, they have given all the resources for the screening of these. But while our conversation with the community health workers, they mentioned they have the resources, they know the procedures, but very few members come for the screening methods. So they tell that if one of the medical officers in our interview told that if people go for regular screenings, there are chances that there can be a decrease in burden on the cancer, and they also told they have a barrier that if they find any case positive, they are not able to contact the nearest tertiary care hospital. So they told that they need one medical record system so that they can keep the track of the patient status.
So unless it's mandated, I think it won't occur. Thank you.
Sorry, ma'am.
No, I just said unless it's mandated by policymakers, the 100% screening I think won't occur as per what you have mentioned. Okay, thank you.
Okay, my question to you is, you have mentioned simple random sampling method. Simple random sampling method, how did you carry out among 385 people in the community?
Thank you for the question, sir. We have collaborated with the medical officers and we have visited various households. Due to the time constraint, we have selected on the random basis the family members in the house.
That is not random method.
It's a convenient probability sampling.
Fine. You have validated your questionnaire. How did you validate your questionnaire?
Sir, our part 1 questionnaire was validated. It was face validated by one of the medical oncologists from the NIMS and one of the SPM faculty from our college.
My question is, you have worked with the community health workers. So you have, out of this 20 were your interview persons. But do you think the sample size what you got is little low about that? Any comment on that?
Thank you for the question, sir. We have selected 26 community health workers. Since our study was a qualitative study and we have used the principle of redundancy and saturation. Based on that, we have noticed that our responses began to repeat after the 20th community health worker. So we have selected the sampling size as 20.
Great.